righty. Hello, everyone. Welcome. Thank you so much for joining us today. My name is Michelle Georges, and I work here at the Carroll Center. And we at the Carroll Center for the Blind are honored to be partnering with Apellis Pharmaceuticals to bring you part one of our two-part Geographic Atrophy webinar series. So thank you to everyone for tuning in. And just know that there is a part two, and we'll share more about that towards the end. Now, before we begin, I would like to go over just a few housekeeping items. To start, we are offering CEU credits for vision professionals who are interested. I will be sharing an entrance code right now, but please stay to the very end of the session so you can get your exit code, at which point we can verify that you were here for the session. So for the entrance code, please note Apple, APPLE, apple like the fruit. And once again, you will get the exit code at the end of the session. Now, please note that this session is being recorded and will be shared with everyone after. So whether you are able to tune in or you want to share this with someone later on, you will have full access. Once our team is ready to go with the recording, we will send it over to everyone who has been registered for this session. Now, we do have the question and answer, the Q&A feature enabled here in this Zoom webinar. And you are able to pop any of your questions into that chat. We do recommend that you do so as the session goes on, so that at the end of the session, when we are ready for questions, we can look through and see what you may have asked. We do want to kindly ask that everyone keep their questions broad instead of specific to your own diagnosis, because our speakers may not be able to give individualized medical advice in a setting like this, and therefore may need to reach out to you personally after. So we do ask that you keep your questions as broad as you feel comfortable. Now, without further ado, I'd love to turn it over to our first speaker of the session, Dr. Michelle Liang, who's going to kick us off. Now, Dr. Liang is a board-certified vitreoretinal, I had to take a moment on that one, vitreoretinal surgeon at the New England Eye Center, and is an associate professor of ophthalmology at the Tufts University School of Medicine. Dr. Liang treats a very wide range of medical and surgical retinal conditions, including macular degeneration, diabetic retinopathy, and retinal detachment. Dr. Liang, thank you so much for joining us today, and I'd love to hand the microphone over to you.
Great. Thank you so much for having me. This is a great idea, and hopefully we can kind of increase awareness of retinal diseases, specifically macular degeneration. So I'm just gonna start this here. All right. Can everyone see my slides if I go?
They look good for us?
Perfect. Okay. So this first webinar, I wanted to really just talk about the basics of macular degeneration and specifically geographic atrophy, which has become a hot topic more recently. And so if we back up a moment, there's probably a wide variety of people that are on this webinar. So if we just take a eye in cross section. So at the front of the eye, we have the cornea, which is the clear front, and then we have the lens. And in the back of the eye, the retina is the back lining of the wall of the eye. And so when we have light go through our eye, it goes through the cornea, through the lens, and then the light hits the retina. And specifically, the macula is the center part of the retina. And then all the signals that come from the light then travel to the optic nerve and to the brain. And so when you go to your eye doctor, this is basically what it looks like when we look at your eye. And so on the right here, you have your optic nerve, which is kind of like this white circle. You can see your blood vessels. And then the center part, again, this is the macula. So this is the very center part of the retina. And this is the tissue that's responsible for your reading vision, driving, helping you recognize faces, and doing your close work. Oh, okay. And so, again, this specifically is on understanding macular degeneration or age-related macular degeneration, and specifically geographic atrophy or GA. And so there's been a lot more commercials and awareness of this recently because there's been two new treatments that have been improved in the last 2 years, whereas typically in the past we wouldn't have been able to actively treat this disease. So we'll talk about what is age-related macular degeneration? What is the subset of geographic atrophy? And then we'll talk about kind of the early signs and symptoms of the disease, what's involved in the diagnosis of macular degeneration, and then what's next. So when we're looking at all cases of macular degeneration, it is the leading cause of severe central vision loss in patients over 50 in the United States. For 2025 data, over 25 million North Americans have AMD. And while it can start in your 40s, most of the vision loss happens in patients over 65 years of age. And as the name implies, the risk increases with age. And so 20% of patients age 65 to 74 have macular degeneration, and 40% of patients over 75 have macular degeneration. And so when you're looking at all comers too, as far as macular degeneration, 90% of patients have the non-exudative or dry type of macular degeneration. This really means that there's kind of some aging changes that we can see in your eye, but oftentimes the vision can be good until the very advanced stages of geographic atrophy. In contrast, most people in the past have talked about wet macular degeneration. So 10% of patients will actually have this subset of disease. And this is when you can have a leaky blood vessel underneath your retina that causes serous fluid or sometimes protein or blood to develop in the retina. And that causes visual symptoms, and that can happen very acutely. And then this typically is what people have been talking about, that they get injections of medication into their eye for treatment of wet macular degeneration, as that's been the gold standard of treatment for the past 20 or so years. And so looking again at patients with macular degeneration, with either type of disease, because the effects are in the center part of the vision, when there's pathology here, they kind of cause the same symptoms. So patients might have difficulty reading the newspaper, difficulty reading their mail and doing their bills. Oftentimes it's harder to recognize faces. People have trouble watching TV, and oftentimes people can lose their ability to drive. And along with all of these things, they lose their sense of independence, which is obviously really important. And so looking here at dry macular degeneration versus geographic atrophy, on this photo to the left, so again, this is a picture of a normal retina. So again, you have your optic nerve, which is kind of that white circle on the side. You have your blood vessels. And then the center part, again, is that macula. And that's what it should look like when we look in your eye. This middle frame, you can see that there's kind of these little deposits or yellow deposits or pigmentary changes. And we would classify this as intermediate dry macular degeneration. So sometimes we can see this in your eye, but the vision might actually be relatively preserved. There's also early macular degeneration, in which case you just have fewer findings than what we have at this photo. And then in contrast, you can have advanced dry macular degeneration. And so specifically, this involves GA or geographic atrophy. And so you can see here, that's the normal retina. And then so you can see here, this is a geographic area where the retina has become damaged and thin in the center part of the macula. And that's why it's called geographic atrophy. So you can see that little outline of damage, and that can cause significant visual issues. And so looking specifically at geographic atrophy, despite advances in treatment of wet macular degeneration over the past 2 decades, geographic atrophy is still an important cause of permanent vision loss in macular degeneration. The thought is that the progressive retinal degeneration and outer retinal atrophy is due to an overaction of the complement system in our bodies, which can lead to inflammation and retinal damage. And the thing here is that while it can progress slowly, the vision loss is irreversible as it spreads to the fovea. And that's why it's so important to recognize it early. And so, again, as there have been new treatments more recently, we've had some patients studied in clinical trials. And so, in a clinical trial that was performed a few years ago, within 1.6 years after diagnosis, 67% of patients with geographic atrophy lost their ability to drive. And then initially, the lesions of the atrophy start extrafoveal or outside the very, very center part of the vision. And these lesions can progress to involve the center in 2.5 years. And then over 2 years of follow-up with these patients, 75% of patients lost 5 letters of vision over those 2 years. So those 5 letters equate to kind of one line of vision when you're at the eye doctor. So 75% lost one line of vision. 50% of patients lost 10 letters or 2 lines of vision, and 25% lost 15 letters or 3 lines of vision. And so you can see here this schematic on the bottom. Typically, patients can be very asymptomatic in the beginning of the disease because you can see the very, very center part of the retina is not involved. But as that area of atrophy depicted in yellow grows and then encompasses and eventually involves the center part of the vision, you can see that the vision will decline. And so, how do you get diagnosed with macular degeneration? Sometimes you really have preserved or only mild reduced vision. So, when you see your eye doctor, this top photo on the left, that's a picture of the back of your eye. Again, if you've seen these at the eye clinic, you can see these are those little drusen or pigment deposits underneath your retina. And this top right image, that's an OCT. Basically, all of our patients with macular degeneration will get this, and it's an optical coherence tomography. And it takes your retina in cross section. So essentially, the top layers are the layers of the retina, and the bottom, you can see those little bumps underneath the retina, and those are those kind of drusenoid deposits or pigmentary changes. But the very center part, that fovea, that's kind of what you see right in the middle. And if that's preserved, then typically you might not have a lot of symptoms. On the bottom photo here, you can see that there's more atrophy here. And so that's kind of where the retina has become damaged. And you can see in the image to the right, the outer part of the retina has become much thinner. You don't see those same lines that are well delineated as in the top image. And because of that damage, the vision will decline and patients will have more difficulty. So this is that same patient that was at the bottom, and this is how you can see that the disease has progressed over time. So in 2020, you can see that there was a little bit of pigmentary changes on the bottom part of the retina, and then off to the side, you could see that there was a little bit of atrophy depicted. You could see kind of like that white, kind of linear, we call it hypertransmission, but essentially this is a technology that uses light to penetrate through the eye. And because the tissues aren't as healthy there, the light actually penetrates a little bit deeper. And you can see that that's the small area of atrophy they had in 2020. And then 2 years later, you can see that atrophy has actually grown. So off to the side a little bit, there's a greater area where that outer retina has become damaged. 1 year later in 2023, it's even larger. And then a year later, you can see that actually the center part of the vision has become more compromised as that geographic atrophy has progressed and involved the center part of the vision. And so, as far as diagnosis, when you go to the eye doctor, especially if you go to a retina specialist, you'll see that we like to do a lot of different testing and a lot of different images. So, pretty much anytime you see a retina specialist, we'll do a dilated exam. So, putting those drops in your eyes and taking a look at it at the slit lamp with our fancy lenses. And then we might also get a bunch of imaging. And so, we might do something called the color fundus photography, which is what those pictures I've been showing you. So, that's basically what your eye looks like in the back. This helps us kind of just document change over time. And then again, we use this OCT pretty much in everybody. And again, in those areas of atrophy, you can have hypertransmission of that light into the choroid, which is that tissue underneath the retina. And then more recently, we've been using fundus autofluorescence to help us measure those areas of geographic atrophy. Sometimes when we take a look at the eye, the findings can be unassuming, I would say. And then we do these fundus autofluorescent photos, which is kind of this middle column here. And you can see that those areas that are affected show up dark. And so those are the areas of the retina that are damaged. And it's a lot easier to compare it in those photos compared to the color photos. And so this is an example of that. So on the left, this is what we would see when we look in your eye. And so the center part, you can see there is like a little area of atrophy here. There's some drusenoid changes around it. There's some pigmentary changes. But when you do this fundus autofluorescence, you can really see the striking difference of those islands of geographic atrophy. And again, these are cells that are damaged from the macular degeneration, and they're just much more easy to see on these images. And in general, we know that the disease will progress. So early on, you can have very minimal changes on exam and their OCT. So again, you can have these little pigmentary changes and deposits underneath the retina. This middle column, you can see 3 years later, there's actually a striking amount of atrophy that's developed next to the center part of the vision. But as you can see, it's still outside the sensor, so the vision might be preserved, or the patients can have a little spot off to the side that possibly they don't see as well. But it's not always noticed until it becomes more advanced. And then in this right panel, you can see 1 year later that atrophy has kind of grown. And you can see that both on the color photos and on the OCT that's on the bottom. So that damage that's off to both sides of the center part of the vision. And so typically the disease too is bilateral. So it can be asymmetric, but usually you have macular degeneration in both eyes. And it could be dry in both eyes. It could be dry and wet, dry in one eye and wet in the other, or it could be wet in both eyes. This is a patient that has geographic atrophy in both eyes. And so the left eye is more diffuse. You can see here the vision is 2150, so pretty limited just because that atrophy has involved the center part of the retina. And then in the right eye, the vision is 2060. So you can see this patient still has some central vision, but there's almost a donut of atrophy that's developed around the center part of the vision, and that can limit the vision as well. And this is another patient. So in 2019, there was some central atrophy, but their vision was 2070. And because there really was no treatment at that time and just natural progression of the disease, the atrophy grew. And then 5 years later, unfortunately, the vision declined to 2200. So one of the main things about this disease is education. And so that's why it's so great that you guys are here and kind of learning about this because if you don't know you have it, there's really, not much to consider. But once you have a diagnosis, it's good to know about the different types of things, about the different types of diseases, as well as what to expect. And so with patients that have macular degeneration, it is really recommended that you have a good diet and healthy habits. Researchers have said that a good diet, specifically a Mediterranean type diet, is good to help prevent progression of macular degeneration. Smoking is also a major risk factor for progression, so it's advised that you stop smoking if you do smoke and you have macular degeneration. And the other thing is having regular exams. So oftentimes patients can have macular degeneration and not even know it. And so it's good to get diagnosed. And even after that, even if it's dry and you're doing what you need to do, sometimes your disease can progress and you might not notice it. So it's good to have regular exams with your eye doctor to monitor for those things. And then if you have macular degeneration, someone's probably mentioned this Amsler grid to you, which is kind of like this fancy grid paper that you see, and you can see it online and just probably in your doctor's office. But basically, it's a grid that you can test yourself at home. And this should be one eye at a time. And you can wear your reading glasses if you have them. And basically, all the lines on this grid should be straight when you're looking at that black dot in the middle. Signs of involvement of disease in your macula include distortion or blind spots or missing spots. And this is kind of a representative example on the top right of what you might notice if you're having new signs of macular disease. And then for the past 20 years or so, we've recommended taking eye vitamins, specifically A-REDS 2 vitamins. There are a lot of different formulations that you might see online or in the store, but specifically A-REDS 2, it's what's been studied. And it's a combination of eye vitamins that's really at a higher dose than what you might get like in a multivitamin. And they're very eye specific. And the idea is that by taking these vitamins, it's thought to reduce the progression of disease over time. And so, one of the reasons why we've been talking about geographic atrophy more so with our patients recently is that two new medications were approved by the FDA in 2023, and they're called complement inhibitors. And again, because we think that geographic atrophy is thought to be due to overactivation of our complement system, the thought is that if we inhibit that a little bit, we can slow down the progression of the disease. And so this is important to know because it's not a cure. It doesn't reverse anything that's already happened, but it can kind of slow down that natural progression. And so these are the two medications that were approved. One is Syfovre and the other is Izervay. And it's important if you do have dry macular degeneration, if you do specifically have geographic atrophy, which is what these are approved for, that you talk with your eye doctor to see if you're a good candidate for these treatments. There will be another webinar following this, specifically going more into these treatment options. And then also, once you have your diagnosis, it's good to work with vision rehabilitation centers to help maintain your independence. And so this is a patient of mine. And so you can see on the color photos on the left, there is some progressing atrophy. And again, on these middle photos, this is the fundus autofluorescence. So you'll see us get this. And so those dark areas of damage, even within 6 months, these are 6 months apart, that has grown. So that's a relatively fast rate of occurrence, maybe faster than some other people, but you can see even again on these OCT images, the areas of atrophy have grown even within 6 months. Sometimes we'll see people and a year later, it looks very similar, and a year later, maybe there's only a little bit of growth, but for some reason, sometimes the disease will progress faster than others. And so, by having these treatment options available, our thought is that if we start these treatments before the center part becomes involved, ideally we can preserve your vision and your independence better than we could before. So, in conclusion, advanced dry macular degeneration is a burden that decreases quality of life. These medications, Syfovre and Izervay, are the only FDA-approved treatments for geographic atrophy. And while there's other research that's still being done, our hope that GA or geographic atrophy will become a more treatable and manageable condition because we really honestly didn't have it up until 2 years ago. One of the main things, though, is that it's important to optimize patient selection. We definitely don't recommend this for all patients. And so, if you do have GA, you should really have a meaningful discussion with your eye care provider if this is something that might benefit you. And in general, our ability to accurately and easily quantify disease stability versus progression is crucial for guiding future care of our patients as well as our visual outcomes. And so I think I'll turn it over to you guys now. Thank you so much.
Dr. Liang, thank you so much. This was very helpful. Very a clear understanding of kind of what's going on in the eye, the mechanisms, as well as, just the advancements and understanding what's happening in the eye as well, specifically with AMD and now GA. So thank you again. That was very helpful. And I did see a few questions come in. Just as a reminder, we will be doing questions at the end of the session for both of our speakers. So for now, I would just like to turn it over to our second speaker, Bibi, who will be sharing a little bit more about her personal experience as an individual who was diagnosed with GA, and to share a little bit more about her personal journey. And as Dr. Liang mentioned, some of the resources that could be helpful for an individual kind of going through this process. Bibi, thank you so much for joining us. We know it's really great having you. And so I'd like to just kick it off by, asking you if you can share a little bit about your story. I mean, you and I have chatted before, and I think you have a little bit of a unique start to your vision loss journey. So I'd love to ask you to share a little bit about that, and kind of, tell us what you're comfortable with.
Well, thank you for the invitation. I'm really honored to be here, and thank you, Dr. Leo, for all of that information. Rather more than I was prepared to hear, but there's a lot there, and I'm very fortunate in my journey because I live in the Boston area, and I have access to wonderful resources. And because I have a family history of macular degeneration, I was able to watch my mother, who died at 96 after a very active life, navigate some of the bumps that we all are facing now. Um, she was not somebody who was interested in pursuing technical supports, but she managed her life in a very inspiring way. And that was a good place for me to start. Um, so I think I don't remember, Michelle, if you said this. I never heard the term macular geographic atrophy until quite late in my diagnosis, less than a year ago. I've been getting clinical interventions both, yeah, well, for wet macular degeneration for 3 years. And I've been seeing a retinologist on a regular basis for 6 years. So I've been in that universe, hearing terms, but geographic atrophy was a new one for me. What can I say? Let's see, I have some notes. So I always was getting regular screening. So the progression of the dry version and then the addition of the wet came probably right away. I think in some people who weren't already getting treatment, it could go on for a lot longer. Um, let's see. I have a stable of wonderful treaters. I have a retinologist. I participate in a low vision clinic here in Boston. I have a great optometrist, and they all are in great communication with one another. That's exciting for me to know how many resources are available, because I know it's not true every place else in the country, and I'm very grateful. The Carroll Center has been an extraordinary resource for me in many, many ways. And I've taken some trainings there that have helped me understand what's possible for me in the future, provide tools for me in terms of technology. I've been meeting with a one-on-one with a blind person who's helping me with technology. There's just a lot of things that I'm fortunate to be able to take advantage of. In terms of background, I'm a recently retired clinical social worker from the Cancer Center here. My patients were all people who are dealing with life-ending diagnoses. And so part of my role was to help them navigate coming to terms with a declining situation which they could not change. So there are a lot of similarities, fortunately not life-ending, but a lot of similarities in helping people come to terms with losing their vision. And I would say the hardest thing really is the emotional loss. I mean, the practical, functional things about not being able to see or drive or many things are very real and in some ways easier to deal with than this loss and the grief that go along with coming to terms with accepting what you will not ever be able to do again. And it's a very lonely feeling, and I'm very grateful for all these resources, which have kept me connected with other people who are dealing with the same thing. I'm a big supporter of support groups. I ran them for my cancer patients. They make a huge difference, finding other people who know enough about what you're dealing with that you feel like you're not alone. And that's because blindness is an isolating condition. Finding other people is not easy. So that's a great big aspect of care. Um, let's see, you had asked me also, Michelle. Um, Maintaining my function in the world as a contributing human being has been very important to me. Again, my professional background has been steeped in that concept. Um, and not losing track of the many things that are still possible for me, very important. And there's got to be a balance between realism and hope. Hope is not my favorite word. I find it I won't find the right word, but I don't think it's helpful for many people. I think it misleads people. And I want to get to that. Maybe this is the place. One of the things that I've been aware of is some of these new treatments for GA that are FDA approved. And unfortunately, because of the, let's say, neglect on the part of the FDA managers, there's been so much advertising for these products on television, and many people who really are not in any way suitable candidates for these medications are clamoring, and I've heard this from many people, they're clamoring for their doctors to give it to them. And then, I mean, it's again that false hope because they're not really eligible. And there's the drain on the patient's time and the doctor's time, which has many better ways to be used. So I understand that there's another the FDA is taking another look soon at the efficacy of their policy around what they advertise to the general public, and I celebrate that. I think people are so eager, for something, but it's not fair to mislead them this way. I think it's false. We don't need any more of that. What else?
Phoebe, you mentioned too, I mean, that's a good point. You mentioned not everyone may qualify for these trials, and I believe Dr. Liang had also kind of touched on that not everyone may be eligible. So I'd love to maybe, hear a little bit more from you as well about the resources that turn to. So after, the medical side of things and, understanding your diagnosis and your prognosis. What are some of the non-medical resources that you turn to? You mentioned the Carroll Center and support groups. Would you mind elaborating a little bit on that? Maybe sharing some of the specific trainings you did and more specifically how you felt approaching those types of resources?
So I had a very thorough evaluation at the Carroll Center, which was enlightening to me because I not only got a clearer idea of my own condition, but also was introduced to the resources at the Carroll Center, both the technical, material tools, but also there was this community, which I found incredibly valuable, just recognizing that. I also took advantage of a program where when I was still working, and I realized that my visual skills, my visual status were not going to be able to sustain me in the role that I had. I wanted to learn more um, computer skills in order to continue my work. And I was woefully, I'm not a computer person, and I needed to understand right away that I work with an Apple system.
Mhm.
My hospital worked with Android system, and I needed to learn two separate sets of tools in order to navigate those two things, and I couldn't manage it. I had hoped to be able to continue my work without asking for special accommodation. As it happened, I developed other medical issues and needed to retire anyway, so I was able to avoid that. But I was prepared, and this is something I think is so important, to advocate for myself, to get what I needed, to do what I needed to do, and to push for my rights in that situation. I think it's difficult for many people who are feeling vulnerable to speak up. And I think speaking up and knowing what you're asking for and sticking to your guns is essential. That was, a big lesson from going to the Carroll Center. I also lived there for 5 days in a dorm. It was very interesting. But the most important and valuable thing was being part of the blind community and just spending time, in the public, lounges, in the cafeteria, walking around the campus, being with people who all had much less vision than I did, understanding that you can do these things. And the inspiration of that was fantastic. I mean, I was completely new to the community and to what it meant. And watching people, you know, watching people walk through the dark without missing a step was fabulous for me, because they knew how. So that's, again, it's very hopeful. I think I have a realistic expectation of what's possible for me. I don't know how long I'll be able to continue that way. Again, coming back to the emotional piece, it's very sad. It's very sad. And I have a a psychotherapist, which is incredibly helpful. I'm fortunate enough to have family nearby that are very supportive. But it's a lonely journey, and I think keeping that in mind, if there are any spiritual components to your life, open them up now. It's valuable. You're not alone. You're not alone, and that is such a boost to your ability to say yes to things, and not just hunker down and hide and feel sorry for yourself. It's not helpful. And I don't know, that sounds like a lecture, but there's lots of better things to do with your time and energy than retreat. Um, the more active you can be in retreating, the better. Peer support groups are amazing. Um, and I know they're not available to many people. So I'm very, very grateful for that for me. Other questions, Michelle?
Yeah, one of the things that really sticks out to me about your story, BB, is it's just wonderful to hear that you've been able to access a pretty wide variety of resources. I mean, from practical and technical skill training like assistive tech to peer support to individual therapy, as well as the medical side of things. I know you mentioned before you worked with several retinologists and specialists, so it's great to hear that. And I know you've mentioned to me too, you have others in your family who are a little bit earlier in their journey. Do you find that, your experiences have helped them kind of broaden their horizons or approach the situation a little bit differently now that you've kind of gone through some of that?
Good question. Yes, well, of course, the others in my family are my sisters, all of whom are younger than I and less far along in their journey. And as a family, we've always been pretty A, straightforward, and B, funny. So we talk about the four blind mice and we sing the
Yeah.
song. So it's like, yeah, and yes, they're very much aware of what I'm doing. And as I've said, none of them are as far along as I am, but probably it's coming, and probably, they're not even probably, they are certainly looking to my experience to help them prepare. Um, you know, we're all very fortunate to have very active family relationships with the husbands and children. So, and they're all aware as well. So, um, yes, is the short answer to your question. Yes, it's my example, I guess, is very valuable to them. And we don't dwell on it, but there it is.
Yeah.
So yeah,
Absolutely. And thank you for everything you've shared. I think your example is valuable to others probably on this webinar as well, who may be earlier in their journey and trying to process their diagnosis emotionally and practically, who may be trying to navigate the skills and everything. So I, really appreciate you taking the time to kind of share a pretty vulnerable and, like you said, kind of tough topic, but you do it so openly and very welcoming. So thank you so much for kind of sharing that with us. Um,
you are so welcome. It's been an honor. I've been really looking forward to this, and I thank you for all that. So thank you.
Absolutely. Yeah.
Thank
And,
you.
having both speakers here, I think it goes to show, how closely tied both the, medical side as well as like the practical and emotional side have to go hand in hand. So, with
Yes.
both Dr. Liang's perspective, as well as yours, BB, it's really great to kind of see those two working together. In an example like you, who took advantage of both the medical side and the treatments, as well as, all the extra resources that can help an individual regain their independence. Yeah,
Thank you. Thank you for making this invitation, and I'm happy to have been here. Thank you.
wonderful. Now, with our time left over, I would like to open it up to some questions. So this will be a Q&A for both speakers. I would love to ask my colleague Natalie to share any questions that may have popped up into our chat. Natalie, please start.
The first question we have, you mentioned smoking can lead to an increased risk, Dr. Liang. Do other sources of nicotine increase risk, such as vaping?
Yeah, I think that historically a lot of research has been done on cigarette smoking specifically, just because it had been so popular. And the idea is that you're kind of increasing your oxidative stress to the body, and that can kind of progress the macular degeneration. I think, more recently there have been other ways of smoking, include, or, vaping or cigars. Patients will always ask me. And I think that even though there's not as much research on it, I think the data does show that, anything that's kind of increasing that oxidative stress and kind of inhaling those substances would probably progress the disease and would be a risk factor. And so, obviously, if someone's been smoking for a really long time, me saying something one time, usually it doesn't make them change their mind, but I would say honestly, the more we can talk about it, the more it can kind of we can impress it upon people that smoking really does, obviously affects more than just your eyes. It is really important to consider cutting back. The other thing is that there's been a lot more research on other vitamins or other anti-inflammatories, and so even though the AREDS 2 vitamins is kind of what's been recommended the most so far, there's been research on like turmeric or other anti-inflammatories. So that's kind of really the meat of kind of what the thought is as far as nutritional effects.
Thank you, Dr. Liang. Our second question I'm going to open up to BB as well. Do you either of you know of any support groups specific to GA?
I do not, but there certainly could be one. Support groups are hard to organize and execute. I know from experience, and I mean, I certainly would be eager to participate in one. I could facilitate also if that's something, because I know how to do that. But I'm not, because of the odd way that I discovered my diagnosis, I don't know how other people find out about it. And I don't know, just speaking of my retinologists have been mostly, uh, as doctors often are, apologize to Dr. Leo, more focused on the function than on the emotional aspects. Um, So I would encourage that to be passed along, that if they could give more information to their patients about supports they can get in the community, that would be so welcome. Even if it's just one meeting with a social worker or a clinician, just to expand the awareness of what else is possible and to normalize this feeling of despair, which is part of the job. Oh,
Yeah, I appreciate that, BB, and I definitely, understand as far as, if you had been treated for a wet macular degeneration, probably no one did mention geographic atrophy because one, it didn't really change what they were doing at the time. So it's kind
right.
of like, oh, all of a sudden you have it now, but on honesty, like it probably was there before. It might have been much smaller, but like, and so it is hard to have this kind of new term. And I think the only supposedly the good things about the commercials, and I know what you're not a fan of, is that honestly increasing awareness and having people ask about it. And so this does, we do talk about it with our patients, and you're right. Sometimes we do talk about it more because they bring it up because they've heard of it, or they have a family member or a neighbor who has it. And so for us, like you say, it is, obviously I do kind of focus more on the function, but also I'm not always up to date on other things, I would say, like support groups. I will refer people to low vision, and I feel like those rehab centers, and I think honestly, beyond that, I find that my knowledge is lacking. And so I would say, like, maybe we all could do a better job on kind of knowing what those resources are, just because it's hard for me to recommend something. But that's, a point well taken.
Yeah.
And just to add on top of that as well, I think, it's everything is very region specific as well. So, I think it depends on, I'm not sure where the individual who's asking this question is currently located. If you are in the Massachusetts area, then, I would recommend turning to places like the Carroll Center, MABV, Massachusetts Association for the Blind and Visually Impaired. If you are currently registered with the Mass Commission for the Blind, this is, I think, where the advocacy piece really steps in. Unfortunately, sometimes it does fall on us as the individuals to take that step and to ask the questions of either the healthcare professionals or the rehab professionals. I've found just from my own personal experience as an individual with retinitis pigmentosa that there's actually a lot more resources out there than I ever thought. It's just about finding it. And I know that can be tough, but a lot more resources exist than maybe individuals might be aware of. So, learning from BB's example of staying connected with others, I found that for me, asking around others like myself, where do you go for peer support? Or have you found, a support group that helps? And just learning that way has been the most valuable. So, For the individual asking about support groups, like I mentioned, if you're in the Mass area, I would highly recommend, coming to the Carroll Center or MABV. If you are outside of Massachusetts, it may vary, but sometimes doing a quick Google search can be really helpful, or potentially seeing if your low vision center or a low vision specialist may know of any. So I would say that's probably one of the best ways to find out. Natalie, do we have any other questions on the radar?
We do not have any other questions right now.
Okay, wonderful.
I have a question about alcohol use. Is it?
Yes, please, go ahead.
Yeah, tell me about that.
The impacts of alcohol use?
Yeah,
I would say, yeah, there's been a lot more studies kind of looking at this, and I think that in general, probably, everything in moderation. And I think that some of the studies that I've looked at, like 3 to 6, which is a decent amount in a week, you know, not that it's like okay, but like obviously the more you do something, the probably the more effects of it. And so it's not like I will tell somebody that they shouldn't drink any alcohol or that they should watch it. And I think that in general, just kind of your overall health and kind of the status, um, that's kind of just something to look out for. But also, like you say, like, as far as your life, you want to enjoy what you have. And so I don't limit, a reasonable amount of alcohol for my patients with macular degeneration.
thank you. That's pretty much what I would have guessed.
Okay.
Thank you for confirming that.
Mhm.
Fair enough. And to share with the group, we do have a second part of this webinar series. This was part one of two. Our second part is on October 22nd, and that is going to be the session in which we go over in more detail about the treatments out there of the two treatments available that Dr. Liang briefly touched on. Dr. Liang, we did have a question submitted in advance about stem cell research, and without asking you to go into too much detail, obviously with the understanding that our second session will dive more into it. I was wondering if you can share a little bit about stem cell research and specifically, if that is currently something in the works when it comes to dry AMD and GA.
So stem cell research definitely has been a topic, but I would say actually gene therapy, specifically has been something that's more close to being, an effective treatment for macular degeneration. I think in the past there had been some actually complicated cases where patients were getting injected with stem cells and they would lose vision and there were a lot of complications. So there are some clinics out there that do look for patients that are honestly looking to do anything, right? Because you're losing vision, and so these people are really looking for something to help. And that's not to say that it can't help. It's just you want to be very careful where you get your treatment. But there are numerous research and clinical trials right now for gene therapy, both for dry macular degeneration and wet macular degeneration. And those are all, they look actually very promising. I will say some of them are in phase 3 data. And so we really need to kind of get more information about how these patients are doing, just because in early stage diseases, we're really just trying to see if they're safe. And then the later stages, we're trying to see if it's effective. And so, to date, probably like we've had a few patients, and in the phase 3, it does look promising. So I feel like as far as something that we're looking forward down the road, I honestly would love to have, a treatment option that might work better, or, as far as like wet macular degeneration, last longer. Because obviously these patients are getting injections, and sometimes it's every 4 weeks or every 6 weeks. And honestly, you're lucky if you can go every 3 to 4 months. And so if there's something kind of more durable, that would be great. But those are all, in clinical trials as far as that gene therapy. But, our thought is that maybe over the next few years, we could be looking at something more that we could bring in clinic.
Wonderful. Thank you so much for that. That was very helpful. And, as I mentioned, part two will dive deeper into the two treatments that Dr. Liang has mentioned earlier. We want to take a moment just to thank you both, Dr. Liang, Bibi, for joining us today, for sharing your incredible perspectives, and just kind of more of your expertise in AMD as well as GA. We want to also thank Apellis Pharmaceuticals for sponsoring this webinar series and for helping us, put this all together and really, for being one of the leading charges in kind of the world of research for GA. So thank you so much to the Apellis team. Thank you to these two wonderful speakers. And for those of you that, did tune in for CEUs, the exit code is orange, ORANGE, orange like the fruit or the color. And so if you are interested, please email development@carroll.org, the same address that has been emailing you leading up to this point, and just give us the entrance and exit code, and we will be happy to share a CEU certificate for this 1 hour session. If any other questions pop up, we will be in touch shortly with the recording as well as other helpful information. Thank you all so much for tuning in. Thank you again
Michelle,
to our
just
speakers.
one more thing.
Yeah.
We just got word there is a community circle, which is a monthly 1 hour virtual program hosted by Macular Degeneration Research. And it's a place where people with macular degeneration can join together to share tips, ask questions, and build community. So I dropped the link to that in the chat.
Wonderful. Natalie, thank you so much for flagging that before we hopped off. For those that are currently on the Zoom webinar, feel free to grab that link. Otherwise, I will share it in our follow-up email that I will share it along with the recording. So thank you all, and thank you for whoever tuned in with that added resource. That's always wonderful. See, this is how we stay connected. So thank you all. Thank you, Natalie, again, and we will see you on October 22nd for part 2. Thanks, everyone.
Thank you.